Hey guys, welcome back. We're going to move on to chapter 10 now, which is our medical emergencies. We're going to start out by looking at the national EMS standards. There's quite a few in this chapter. First one is medicine recognize and manage life threats based on assessment findings of a patient with a medical emergency while awaiting additional emergency response. And then a medical overview, assessment and management of a medical complaint. And then we're going to go through the different body systems and different complaints related to each body system. The first one is neurology. So we're going to look at the anatomy, presentation, and management of decreased level of responsiveness, seizures, and stroke. We will move on to abdominal and gastrointestinal disorders, looking at the anatomy, presentation, and management of shock associated with abdominal and management of shock associated with abdominal emergencies. We'll go on to look at endocrine disorders, which are our diabetic emergencies that may cause altered mental status. We will look at cardiovascular, looking at the anatomy, signs, symptoms, and management of chest pain and cardiac arrest. Respiratory, including management of respiratory emergencies of the upper and lower airway. And then we'll look at our genitourinary and renal, including blood pressure assessment and hemodialysis, including blood pressure assessment in hemodialysis patients. Here's a list of the common medical conditions that we're going to go over in this chapter: angina pectoralis, heart attacks, congestive heart failure, dyspnea, asthma, stroke, hypoglycemia, and abdominal pain. As emergency medical responders, you should be prepared to treat any of those medical emergencies that we're going to go through in this chapter. So it's really important that we study the signs and symptoms and treatments of each of those conditions, that you become familiar with them and comfortable recognizing them. Our patient assessment is the same in medical emergencies as it is with anything else that we do. So this is just a little bit of review, talking over the steps of the patient assessment. First thing we're going to do every time, do our scene size up, that 5,000 foot view, looking at everything around us before we even approach the patient. Our primary assessment, getting our general impression of the patient, looking at their airway, breathing, and circulation, and treating any immediate life threats. Moving on to taking a good detailed history, understanding their sample history, signs and symptoms, allergies, medications, past medical history, last oral intake, and events leading up to why they called you. Going into a secondary assessment, looking for anything else that may be going on with them, and then continually reassessing. The first part of that assessment always begins as soon as you get your dispatch information. So review that dispatch carefully, pay attention to any information that you have, identify safety issues, and then as you move into performing your primary assessment, you want to identify those life-threatening injuries, like I said, and if they are unresponsive, you want to move into that primary assessment, looking at any life threats immediately and treating those. Determine if they're responsive or not, introducing yourself, checking airway, breathing, and circulation, and then asking them what their chief complaint is and why they called you. After we understand why they've called, what their chief complaint is, and we've made sure that we've treated any life threats, then we can move into our secondary assessment, where we get a little bit more history from them and we monitor them and continually reassess while we wait for further emergency responders to show up. Our medical conditions can have a lot of different causes, so it's important that we understand the signs and symptoms and how they can be similar in each of the different conditions. With all of these conditions, the first thing that we want to do with all these patients with our initial treatment is stabilization until other EMS providers can arrive on scene and take over. Other EMS providers arrive on scene and take over care from us. So first, we're going to start talking about some of the neurological issues. issues that are generally happening in the brain, causing us to be confused. So we want to look at altered mental status. This can be either gradual or sudden, and it's just a decrease in their responsiveness. We use a acronym AVPU, and this is a scale that we use to assess their mental status. We have alert, verbal, pain, and unresponsive. Now, alert means that as we walk in and we're talking to them, they're paying attention to us, they're tracking our movements, their eyes are open, they're responding, they're answering questions. Verbal would mean we walk in, maybe their eyes are closed, they're not really paying attention to us, but if we talk to them, get their attention, they're able to open their eyes, look over at us, and we can see that they're tracking us and maybe just having a little bit of trouble staying awake. Next would be painful stimulus. So these people, if you've walked in, you've tried talking to them, they're not opening their eyes, you can try to elicit a pain response. Normally, we would do that by pinching the earlobe. You can also pinch right above their collarbone, anything that's just a little bit of a pain response to see if they'll open their eyes at that point. If none of that happens, if they're not tracking you, they don't open their eyes when you talk to them, and you can't elicit a pain response, then we list them as unresponsive. When we are assessing a patient's mental status, we want to pay attention to what the initial level of consciousness is when we first get there, and then any changes that happen while we're there. It's also important, if you have anybody else on scene, to find out if there's been a change in their level of consciousness from the time of injury or illness up until the time that you've got there. We do this to trend to see if the patient is getting worse or if they're staying the same. There are a lot of different conditions that can cause an altered level of consciousness. These can be any traumatic head injury, shock, decrease in oxygen levels, stroke. If we have a slow heart rate, it decreases the amount of nutrients getting to the brain, or high fever. We could also have infections. Maybe they're on medications or there's been some other type of poisoning, low levels of blood sugar or blood glucose, or psychiatric conditions. Even if you can't determine which one of these causes is the reason for their altered mental status, we can always treat symptoms. So try and rule out some of these, try and figure out which one it could be. But in the end, as long as we're treating symptoms, then we're helping out our patients. So our initial treatment for any of these altered mental status neurological issues is going to be maintaining their airway, breathing, and circulation like we do with all of our patients, maintaining a normal body temperature. We want to keep them safe from additional harm. This could mean that we need additional resources to help us. Maybe we need to keep bystanders away. Maybe we need to move things away from the patient so that they don't hurt themselves. If the patient is unresponsive and we don't suspect that there has been a trauma associated with that, then we can place them in the recovery position or use airway adjuncts to help protect their airway. And we always want to be prepared to suction that airway. If for whatever reason they start vomiting, we want to just make sure that it's clear so they don't aspirate or breathe in any of that vomit. Another very common neurological problem that people can have is seizures. This is caused by a sudden episode of uncontrolled electrical impulses in the brain. Normally, our seizures, we're going to see like shaking movements. It could involve the entire body. It could involve only certain parts of the body. Normally, this will last anywhere from 1 to 2 minutes. And after the seizure has ended, the patient will remain in an unconscious or semi-conscious state. Some of our generalized seizures can be caused by high fever. We see this often in infants and young children. It's called a febrile seizure. A lot of times, new parents will call us because of this. And they're very common. They can be treated just by cooling down our patients. We can also have absent seizures. This is a brief lapse in consciousness. Sometimes our patients are just staring off blankly into space. They may have jerking movements of one part of the body or another. These ones are a little bit harder to recognize in our patients because we don't have that generalized seizure activity where their entire body is twitching. With all of our seizure patients, we're going to do the same thing that we do with all of our patients. We're going to monitor their airway, breathing, and circulation and arrange for transport. There are many different things that can cause the seizures. So trying to rule out one or the other and try and figure out based on their history what it might be that has caused the seizure will help with some of that treatment. It could be epilepsy, trauma, which would include our head injuries, or it could be stroke. As we go through and we start asking questions of the bystanders, it can help us narrow down which of those it might be. Our seizures can be caused by a lot of the same things that our altered mental status can be caused by. So here we're looking at decreased oxygen levels to the brain, our high fevers and infections, overdose of drugs and alcohol, diabetic emergencies. We can also have seizures related to pregnancy complications. And then sometimes seizures just happen and we never figure out what has caused them. Treatment for our seizures, usually the seizure is going to be over by the time we arrive on scene. If you remember, they normally only last a minute to 2 minutes on average. And so by the time we get that call that has come into dispatch, dispatch has called us and we've responded, the seizure will be over. If the seizure has not ended by the time we get there, we want to protect them from injury. This is, like I said in the earlier section, about protecting them by moving things away from them. If they're seizing and we're having those full body movements, just make sure that there's nothing that they may end up hitting their body with. Once the seizure has stopped, we want to assure we have airway, breathing, and circulation, placing them in the recovery position and making sure that they don't aspirate. As our patients are seizing, sometimes the muscle wall will actually be twitching and contracting as well, and so their breathing will become irregular. If they don't start breathing normally after the seizure has stopped, we may need to breathe for them, either using a mouth-to-mouth method or a mouth-to-barrier, or if we have a bag valve, or if we have a bag mask device, then we can use that to breathe for them as well. We want to administer oxygen through that mask as soon as possible, and then move the patient into a comfortable position and a private place if they're not already. So that's been our neurological emergencies and things that we need to look for. Now we're going to move into some other specific medical conditions that it's important for us to understand as emergency medical responders, and some of the things that we can do to assess and treat these other medical conditions. So we're going to look at heart conditions. If the heart muscle doesn't receive a constant flow of oxygen, the heart needs to receive a constant flow of oxygen or it will begin to die. The heart muscle itself receives that oxygen through a number of different coronary arteries that are wrapped around the outside of the heart. Those arteries can end up narrowing because of atherosclerosis. And if that happens and they continually narrow, then we end up with angina. Then we could end up with angina, or it could progress into heart attack or cardiac arrest. So first we will talk about angina pectoris. This is when there's an inadequate blood flow with oxygen delivery to the heart muscle. Normally it's described as a pressure, a heavy discomfort for the patients. They may have difficulty breathing, shortness of breath, sweating. Normally, these patients are going to be extremely agitated or frightened because of what's going on. Angina is normally brought on by exertion or emotional distress or something like that. This isn't something where they've just been sitting normally in their chair and all of a sudden they're having this pain. It's normally they've been out doing something and then it has caused it. If this is the first time they have had these symptoms, it may be difficult to determine whether it is angina or whether they're having a heart attack. If they have been treated before, then they may have nitroglycerin, which is a medication that we use to treat angina. If they have that, then we can assist them in taking one of their pills or administering the aerosol spray that they have. If they take one of their pills or their aerosol spray and they don't have pain relief within about the first 5 minutes, you can do another dose. Anytime they have taken this medication, it's important that we encourage them to be transported to the hospital to be evaluated further to make sure that it isn't something more serious like a heart attack going on. When we assist patients with their own medication, it's really important that we always follow our local protocols. Our local medical director and our agency is going to determine if we are allowed to help with these medications or whether we are allowed to give them ourselves to the patients. So angina is caused when one of these coronary arteries that wrap around the heart becomes narrowed and the blood supply and oxygen delivery to the heart muscle is slowed because of exertion, where the demand becomes greater than it can make through the narrowing of those coronary arteries. A heart attack is when there is a complete blockage of one or more of those coronary arteries. This can be caused by either severe atherosclerosis, where they have just completely blocked off, or it may be where a chunk of that has broken loose and traveled farther down and clogged off one of the coronary arteries, or it could be a blood clot, which has gone through and blocked off part of that coronary artery. Our signs of a heart attack are going to be very similar to those that we have with our patients that have angina. These people are going to have immediate severe pain. Normally, this pain is going to radiate from the chest into the left arm, into the jaw, possibly into the back. These patients are going to be short of breath. They're going to be sweating. Possibly they'll be nauseous and vomiting. It's important to know that men and women can present differently. Men will generally have that pressure in the chest, the arm, and the jaw pain, whereas women will normally present more with the nausea, the vomiting, and pain that's related more down into the abdomen. If that blocked area of the heart is large enough, it may cause the muscle in that area to die and the heart may stop completely. If the heart muscle has stopped moving completely, that is when we call it a cardiac arrest. And with cardiac arrest patients, that's when we need to start CPR immediately. We need to call for additional help. If that area of the heart that has stopped receiving nutrients is big enough and it has stopped beating completely, that is when we call it, that is what we call cardiac arrest, and we need to begin CPR. Hopefully before it progresses to that though, we have been called and we're able to get additional help there. We're able to talk to them, calm them down, relieve some of that anxiety, make sure that we're continually reassuring and reassessing our patients while we await further EMS response. With these patients, we want to move them as little as possible. It's important that we don't have them get up and walk around. Any exertion that may cause that heart muscle to need more oxygen or blood supply than it can receive is going to further the damage. So anytime we can carry them or move them ourselves, it's important to do that. If available, we want to help these patients in taking some aspirin. Normally, we're going to do either 2 or 4 of the low dose aspirin. The low dose aspirin is the 81 milligram tablets. We want to make sure that it's the kind that they can chew up. So we're going to take, like I said, either 2 or 4 of those. So 162 milligrams or 324 milligrams of aspirin. If you have oxygen, you can put them on oxygen as well. Because of the severity of this illness, we always want to be prepared to start CPR if they do go into cardiac arrest. If we have our AED available, make sure that it is with us and make sure that we're ready to use it. When giving our patients any medication, whether it is aspirin or nitro or even oxygen, which is a medication, it's important that we follow our local protocols for administration of those medications. The next cardiovascular disease that we'll talk about is congestive heart failure. Congestive heart failure is a pump problem. So it's caused by the heart not pumping effectively to circulate the blood throughout the body. The failure is a failure of the pump, which is the heart failure part. The congestion is throughout the blood vessels in the body, whether it be in your extremities or whether that congestion is in the lungs. Some of the signs and symptoms that we look for with our congestive heart failure patients, we're going to be looking for shortness of breath. This can be a major symptom as that congestion is in the lungs and they're starting to get fluid buildup in the lungs and inadequate oxygen movement throughout the lung tissue into the body. With that, they may have rapid or shallow breathing. You may hear, if there's enough fluid buildup in the lungs, you may hear a moist or gurgling sound as they're breathing. They may have enlarged neck veins. This is called jugular vein distension. It is a late sign in our congestive heart failure patients. We also want to pay attention, and one of the more common things that we can see is swollen ankles. So ask them if the swelling is normal, if they're seeing more swelling than normal. Most of these patients are going to know if they have congestive heart failure, and they will know what is normal for the swelling in their ankles. So ask them if it's a normal amount of swelling or if they're seeing more than normal. Some of the things that we can do for these patients: place them in a position of comfort. We can also sit them in a position where some of that fluid is able to drain using gravity, hopefully down back into the lower parts of the body. We can give them oxygen. And with all of these patients, we want to get additional help coming, arrange for an ambulance intercept if you're not working on an ambulance, and arrange for them to be transported to the hospital. Dyspnea is a term used for shortness of breath or difficulty breathing. Our CHF patients can have this. Any of our heart-related patients with angina or heart attack can all have this. But also, it could just be that it is a pulmonary disease itself. It's something happening in the lungs. So it could be heart or it could be lungs that is causing this shortness of breath and difficulty breathing. So we could see our chronic obstructive pulmonary disease or COPD. It could be emphysema, bronchitis, pneumonia, and one of the most common is asthma. Any patient that is having difficulty breathing, we want to start out by doing our ABCs: airway, breathing, circulation. So we want to check the airway to make sure that there's no obstruction. And we can also check this a little bit by getting patient history, make sure that there's no chance that they have anything stuck that is obstructing the airflow in their upper airways. We want to check the rate and depth of their breathing. place them in a position of comfort. Most of these patients are going to find a position in which they feel the best to be able to get the most oxygen in. So a lot of times they'll be leaned over and have their arms out on their legs, kind of in a tripod position is what we call it. With these patients, we want to just continually talk to them, reassure them, help reduce their anxiety, and administer oxygen if we have it available. Like I said, asthma is one of the most common reasons that we see dyspnea. This is an acute spasm of airway passages in the bronchi. This is acute spasms of the airway passages in the lungs associated with excess mucus production. This can be caused by either allergic reactions, it can be caused by exercise, infection, and we can also see it with severe emotional distress. Asthma attacks are very serious and they kill thousands of patients every year. We're able to hear that they're having that difficulty breathing, and sometimes you can hear it from across the room, sometimes you can hear it with your stethoscope, but they will have a wheezing sound as they breathe in and possibly in and out. They're going to be trying to create pressure so that you may see that they have pursed lips as they're trying to push the air out. The problem is air trapping in the lungs. They're normally able to get it in, but they can't get it back out. So this is a medical emergency. These patients need to be treated either by advanced life support on an ambulance or at a hospital immediately. Stroke is the leading cause of brain injury and disability in adults. There are nearly 800,000 adults that have a stroke every year. So this is a huge problem that we need to pay attention to. Strokes are caused by blood clots that block the blood supply to parts of the brain. So just like a heart attack is blocking where we have blood flow restricted to certain parts of the heart, a stroke is a clot of some type blocking that blood flow to the brain. These patients are going to have a headache. They may have numbness or paralysis on one side of the body. And often they are confused and dizzy. They may also be nauseous. You may see as they have that weakness on one side of the body, you may start to see drooling on that side of the body as they're unable to keep secretions in. They may have the inability to speak, difficulty seeing you or tracking your movements. They can sometimes have unequal pupil size. As we're looking, one may be smaller than the other side. If it is a large enough area of the brain that has been affected, you could start to see them become unconscious. They may have seizure activities. And unlike the heart attack patients, where the blood flow has stopped the heart from beating, with these patients, we will often see a respiratory arrest happen before a cardiac arrest. So they may stop breathing first. There are many different tools that we can use as emergency medical responders to try and determine if the patient is having a stroke. One of the most common that we will see in pre-hospital care is the Cincinnati Pre-Hospital Stroke Scale. This is used to help us determine if the patient is having a stroke. There is a 72% probability that the patient is having a stroke if one of the three elements are found. We can look at a table from the textbook helping us explain and understand the Cincinnati Pre-Hospital Stroke Scale. So the first thing we're going to be looking for is facial droop. So we want to see if they have any weakness on one side of the face or the other. The next thing we're going to look at is arm drift. And to decide if the patient has arm drift, we're going to have the patient put their arms out in front of them and close their eyes. And if they're able to hold their arms out, then there's no drift. But if they put their arms out and they close their eyes and you see one of their arms drift down or even just fall completely, they may not even be able to get to where they close their eyes. You may have them get their hands out and one arm just falls immediately. That would be an abnormal finding or a positive on the arm drift. And then the next one of the tests that we do is we check their speech. We try and have common phrases that we say or have them repeat back that help us determine if they have abnormal speech. The one that we use most commonly is have them repeat back, "You can't teach an old dog new tricks." So after you have them repeat that back, you'll determine if they're slurring their words, if they're using wrong words, or if they're unable to speak completely. Then that would be a positive finding on the Cincinnati Pre-Hospital Stroke Scale. Our treatments for stroke patients, we're going to maintain an open airway, administer oxygen if we have it. If we need to breathe for them, we will also do that through our bag valve mask. If the patient is having seizure, as with our other seizure patients, we're going to just make sure that we try and prevent further injury by moving things around them and protecting them. And if our patient is seizing, we just want to make sure, as with our other seizure patients, that we're moving things from around them and making sure that we're not, or making sure that we prevent any further injury as they are having that seizure. And like I said, if that has happened, if they are seizing, once that seizure has stopped, we may need to provide rescue breaths for them. If our stroke patients are unresponsive, we want to place them in the recovery position. We can provide emotional support for these patients, even if they are unresponsive or if they're not. A reassuring touch from the responder, gently reassuring them and helping them calm down. There are treatments for strokes. We can give, or the hospital can give medications that will help dissolve those blood clots, or they may be able to go in surgically and remove those blood clots. But it's important to know when the last time anybody saw them normal. And that will help determine whether or not they're able to give those medications. So as you're doing your assessment, as you're gathering history, you need to find out the last time they were seen normal. So if this means the last time anybody saw them was when they went to bed last night and they woke up like this 7 hours later, the last time anybody saw them normal was the night before. It could be if they have family who came over and found them like this, maybe nobody has seen them for a day or two. That's also important to know. So whatever information we can find out about any information we can find out about the last time they were seen normal is very important as we arrange for our prompt transport to the appropriate hospital. And hopefully that is going to be a stroke center in your area. Diabetes is another very common disease in the United States. It is caused by the body's inability to process glucose effectively. That inability to process glucose normally comes from a reduction in the production of insulin. So our body produces insulin, which is the key to move glucose into the cells. And if we're unable to move the glucose into the cell, if we're unable to move that glucose into the cells, then they become starved for glucose. And that's when we'll start to see diabetes. With our diabetics, there's a couple of different things that we need to pay attention to. The first one that we're going to look at is hypoglycemia. hypoglycemia. And if you remember, hypo means low or below. So this is when the body doesn't have, so this is when the body has enough insulin in circulation, but not enough blood glucose to actually send into the cells. Signs and symptoms of our hypoglycemia. These patients are going to be pale, cool. They're going to have moist skin. So we say diaphoretic is the term for that moist skin. They will often have a rapid, weak pulse. They're going to be dizzy, confused. They may be unconscious even because of this low blood sugar. Low blood sugar is a serious emergency that needs to be treated immediately, as our brain can only function so long without sugar. Oftentimes, these hypoglycemic patients are described as appearing drunk, and so it's really important that we get good history to rule out and know that they're not altered because they're drunk, but they're altered because they have low blood sugar. If you are trained and authorized by your local medical guidelines, you may be able to administer oral glucose for these patients. Once the EMTs or paramedics arrive, they will actually use a glucometer to check the levels of blood sugar in the body and then help determine how much they need to give in terms of oral glucose or even IV glucose later on. If your hypoglycemic patients are unresponsive, we're going to do the same thing that we do with all of our other unresponsive patients. These patients, we're going to monitor their airway, their breathing, and their circulation. At this point, we're not going to give them any oral glucose or anything else that we may have in the mouth. Anything that we place in their mouth at this time, it can become something that they can choke on. If you do have oral glucose or tablets and you are very careful about how much you're using and how you're doing it, you may be able to stick a little amount in the inside of their cheek, and that will absorb into the body. This isn't something where we're squeezing an entire tube of oral glucose in, but maybe put a little bit on like a popsicle stick or a bite stick and sticking it back there, letting that absorb a little bit more, just to make sure that we're not causing anything where they may choke on it, and always being ready to clear the airway if you do get too much in there or cause any secretions. So we can also have diabetic comas, and diabetic comas occur when the body has too much glucose and not enough insulin to clear that glucose. So we're going to use a good history to try and figure out, using our signs and symptoms, see if they have a history of diabetes. These patients, this is going to be our hyperglycemia patients, so they're going to have too much Next, we'll talk about abdominal pain. So within the abdominal cavity, there are different organs. We have hollow organs and we have solid organs. And the pain related to each of them can be a little bit different. So acute pain is something that has happened right here, right now. It's normally caused by a irritation of the abdominal wall. It could be from an infection, or maybe we have blood in the abdominal cavity related to trauma. With the organs in the abdominal cavity, sometimes we can end up with what's called referred pain, or pain in another part of the body that is related to those different organs. And with our abdominal pain patients, we're often going to see nausea and vomiting and fever with all sorts of different abdominal complaints. Sometimes with that nausea and vomiting that we will see in our abdominal injury patients, it could be that they are vomiting blood. This could be because they are bleeding either in their stomach or in their esophagus. So determining the color of the blood that we see in those patients is important. Any of our patients that have abdominal pain, we're going to monitor their vital signs. We're going to maintain their airway, breathing, and circulation, keep them as comfortable as possible, and arrange for transport. One of the more serious things that we could have with our abdominal pain patients is called an abdominal aortic aneurysm. This is one cause of acute abdominal pain. It occurs when the layers of the aorta, or the main artery that's coming out of the heart and supplying blood to the lower extremities, where it becomes weakened and the different layers of that artery start to separate. Risk factors for this are going to be patients who are diabetic, if they have high blood pressure, or if they're heavy smokers. If the patient does have a AAA or an abdominal aortic aneurysm, it can often be described as kind of a tearing pain, either in the back or in the stomach. And these patients will have severe pain and profound shock, meaning that their blood pressure is going to be lowered and they're not getting adequate circulation to their body. These patients we want to place in a position of comfort, treat for shock, move them gently so that we don't cause any further rupture of that aorta, and arrange for immediate prompt transport. Our kidneys filter waste from our body, and sometimes patients who have kidney disease are now unable to filter that waste from the body. So some of these patients with chronic kidney or renal failure need to undergo what's called hemodialysis. This is where the blood is actually taken out of the patient, ran through a machine that cleans it out and gets rid of that waste product, and then puts it back into the body. Most of these patients who go through hemodialysis are going to have what's called a shunt implanted into their arm or leg. A shunt is a surgically created connection between the arteries and the veins. And the reason we need to pay attention to this is we need to ask our patients if they have anything, because if they do, then we need to not take a blood pressure on that limb. Oftentimes you'll be able to feel it. So if you see any large lumps or nodules on their arms before you're taking a blood pressure, make sure and ask them if they do have a dialysis shunt, and if they do, just move to the other arm. Sometimes patients may be experiencing emergencies specifically related to their dialysis treatment. And that could be that they haven't made a dialysis appointment that they should have, or maybe at their dialysis appointment, they ended up taking too much fluid off and not putting enough back. So we need to look for low blood pressures due to changes in the body. This can lead, these low blood pressures lead to shock due to decreased blood pressure. And the other thing that we look for is abnormal levels of electrolytes. Those abnormal levels of electrolytes can lead to cardiac dysrhythmias, causing them to go into lethal arrhythmias where we actually need to do CPR on those patients. We can also have infectious diseases or epidemics. We've all lived through COVID-19 at this point. That's one of those infectious diseases that spread person to person, direct contact, or in contact with the blood. We've talked about protecting ourselves from some of these things in chapter 2 when we talked about workplace safety and wellness. So just making sure that we are aware of infectious diseases that may be causing problems with patients and that we are taking steps to protect ourselves. Here we can see a list of some of the epidemics or pandemics that have occurred just in the last 20 or so years. We had the SARS pandemic, we had the swine flu in 2009, 2010, and then as we all are aware, we had the COVID-19 pandemic. It started in 2019. So we're going to go through the summary of this chapter. Medical conditions can have a lot of different causes, and they will often have similar signs and symptoms. So it's important to get a good history on our patients and to try and start ruling out different causes. Altered mental status could be sudden or gradual. With these patients, we just want to make sure we're assessing that AVPU scale to see what they are responsive to. If we have seizure patients, this is that sudden episode of uncontrolled electrical impulses. We don't want to restrain or hold down these patients, but we do want to make sure that there's nothing around them that they could injure themselves on. Wait for that seizure to stop, ensure that they have an open airway, and then place them in the recovery position. And then we talked about a lot of different medical conditions that you may encounter as an emergency medical responder, including angina, heart attacks, congestive heart failure, hypoglycemia, hyperglycemia, and abdominal pain. Although each of these conditions really needs to be diagnosed by a physician, what we can do as emergency medical responders is we can recognize the symptoms and treat them as we are preparing them for transport to the hospital. Go ahead and go into our review for this chapter. Question number 1, signs and symptoms of stroke include all of the following except numbness or paralysis, high fever, drooling, unequal pupil size. Answer for this one is high fever. Question number 2, which of the following actions would not be appropriate when managing a patient who is suffering a heart attack? Place the patient in the most comfortable position, administer oxygen if available, be prepared to administer CPR, move the patient as quickly as possible to ambulance for transport. And the answer is move patient as quickly as possible to ambulance for transport. Question number 3, hypoglycemia occurs when a patient consumes too many high-fat foods, has enough insulin but not enough blood glucose, suffers severe dehydration, or has too much blood sugar and not enough insulin? And the answer for this one is going to be B. Has enough insulin, but not enough blood glucose. All right, guys, I know that was a little bit longer. A lot of information about medical emergencies and some of the different conditions that we may see as emergency medical responders. It's just a brief overview. Hopefully, you guys were able to learn some good information there, and I'll see you at the next chapter.